Hello, everyone, and welcome to today's ACP Live Remote Non-CE offering. Today's non-CE topic is going to be the science behind electrotherapy for neuro reeducation. I'd like to now introduce Deborah Capella, who will be our presenter today. Debbie is a physical therapist and clinical program consultant for ACP based out of Maryland. So thank you so much, Deb. I'm going to now turn it over to you.
Thank you. Good afternoon. We're going to be talking about using eSTEM to assist with neuro reeducation specifically. So what we're going to be doing is going through a couple of options for this, but we're going to talk about how do we use eSTEM for neuro reed, and specifically what is patterned neuromuscular reeducation about, and what is PENS, that is a type of eSTEM. How does it work? What is it? How does it work? How can I look at normal movement patterns and abnormal movement patterns and see the benefit of introducing patterned eSTEM into that treatment plan? What are central pattern generators? That's a central topic we're going to talk about, in the concept of neuroplasticity. And then we'll end with a little bit of an example, as well as maybe some ideas on where we might be able to fit this into our care. The first thing we want to sort of remind everybody about is the fact that, we're all very well versed in muscle reeducation. And if we're comfortable with using eSTEM for strengthening, very often that waveform is specifically designed to target the muscle fibers. What I would like to introduce and talk about the physiology behind is how do we attack the neural side to muscle performance and to performance. So we're going to talk a little bit about that neuroplastic capability and trying to influence normal firing patterns via eSTEM. So as I mentioned, patterned electrical neuromuscular stimulation is a type of eSTEM that is specifically designed to enhance neuromuscular performance. Some of those neuroplastic changes, as well as treating and reversing some of the motor neuron disuse atrophy that we see that comes with disuse. This is a review of different ways to improve functional gains via eSTEM. Our conventional eSTEM is something that we've all studied before, usually with a sustained contraction, where we're working on just an agonist muscle to perform an activation, usually along with a volitional recruitment. And that really is focusing on more of the muscle fiber. Pattern eSTEM, on the other hand, is really working on a motor twitch level, but we're working in a very specific timing pattern in a very specific way so that we can work on the agonist and antagonist in ways that we can work on coordination and efficiency of movement. So it's really great when patients can't do a lot of exercise themselves, because we're almost bypassing that piece of it and focusing on getting the neural side up to speed to assist with that movement. Both types of this current are going to be activating our fast twitch muscle fibers. We'll actually talk a little bit about that coming up in a couple of slides. But that's an important concept to understand, that this is an in to some of our muscle fibers that we might have trouble getting in the clinic when we don't have the ability to use eSTEM as a tool. As I mentioned, PENS is a form of stimulation that's going to be replicating correct firing patterns of muscles. And that could be an agonist-antagonist pair, or it could be a reciprocal pair if we're working on symmetry, for example, right versus left. We have several different patterns we're going to go through. The first being triphasic for a quick ballistic movement, biphasic, and then functional reciprocal patterning. The PENS waveform is going to create contractions, little twitch contractions, that are going to neurally replicate the sensory input and then the voluntary firing activity of the sensory side and motor side of a particular movement pattern. So for the triphasic pattern, what I want you to visualize is what happens when we're going to be doing a task. Maybe it's standing up. Maybe it's weight bearing and getting that automatic control to stay up against gravity. Maybe it's feeding myself. So let's say we'll take the example of the biceps triceps, where I'm going to then, send a message, and it's going to tell my agonist, my biceps, to say, we need to bring this to my mouth, for example. My biceps will fire. And then we know that we have to have control of that. We can't just in isolation fire the biceps, because if I did that, I would be flailing my arm and I would have no fine coordination or end point. So we really rely on the triceps actually to assist us with a little bit of overlap of this firing pattern. And then I re-fire my agonist at the end so that I fine tune the movement. So this is what we call our triphasic pattern, and it's the one we're going to focus a lot of discussion on today, but it's one of the patterns that exists in our hardwiring, so to speak, when we think about automatic movement and things that happen without our cognitive input. The other two types of patterns that we have hardwired as well are things that might be faster and a little less fine-tuned at the end, where we have a biphasic pattern. So that could be something like an arm swing during walking. You can kind of picture my shoulder flexor will fire and my shoulder extensor kicks in to slow me down. And then I'm going to repeat that as I'm going through my swinging arm motion. Another type of pattern that we see frequently is a functional pattern. And this is what's kind of that underlying rhythm of symmetry when we're talking about walking. So if I'm walking, right, I have a right, left, right, left, right, left. And to be symmetrical, there should be a pretty standard timing between when the right side is contracting and when the left side is contracting. So that pattern is something that we can also be tapping into. So again, triphasic patterning, biphasic patterning, and functional patterns. So I want to talk a little bit about the research behind what we know about patterning. And the first thing to recognize is, might call your attention to the fact that this is not new. This is not a new thing. We figured this out quite a while ago, that this is how we started talking about this triphasic pattern. Also had a little bit of research that comes in about biphasic patterning. But as we move forward in years, you can see that we start to really fine tune what we know about this triphasic pattern. Triphasic patterns are centrally programmed, right? They are things that we have there to make the most efficient movement pattern possible. We come to the conclusion back in the 90s that this is sort of our basic unit of movement control. So when we talk about influencing movement, let's start with the building blocks. The building block is this triphasic pattern. Moving forward in time a little bit further, we start to look at some dysfunction. What's happening when things go wrong? What do we see that happens to these firing patterns? So, of cerebellar dysfunction, we look at that EMG testing and we see that there's a prolonged acceleration on that first burst. So that's contributing to that person's dysfunctional movement pattern. And then all the way down into 2015, where we see that, hey, you know what, neuroplasticity is there. We can influence this. We can actually return this firing pattern back to that more efficient pattern if we give it enough input. And that's what we're going to talk about a little bit today. How do I maximize my input to this pattern? When we talk about pens, one of the things I like to talk about is, why would I do this? What's going on? What's the big deal? And how is it working? And I like to know these things before I think about incorporating them in my treatment plan. And the physiology behind pens to me is very interesting because it's attacking this problem. And we can think of the problem as being functional strength or functional performance. Maybe that's a disuse atrophy situation. I haven't used this system enough. I haven't sent signals down these neurons. I haven't contracted the muscles very much. And so just like we have muscle fiber disuse atrophy, we have motor neuron disuse atrophy, because why would I have all of this great, fantastic action potential ability if it's never being incorporated? The body will gradually lose that nice, perfect ability. So we're going to take eSTIM and we're going to apply we're going to start action potentials via the eSTIM. And these action potentials at a high volume, 600 to 800 repetitions in 15 minutes, is a big piece to telling that nervous system, wow, look at all of this needs to be accomplished. I better start improving myself and getting myself back up to speed again, because the disuse has gone on long enough. I'm needed. So things that happen when we do this high volume of action potentials is we tell the nerve cell itself, pick up your game a little bit, right? I'm needing nerve growth factor. Nerve growth factor is something that is needed for a lot of different things. It's going to help the cell realize and support some of the enzymes that are used to assist with propagating that action potential, right? We need sodium, potassium, and calcium channels in order to send that signal along the nerve effectively. I need protein, right? I need protein along my myelin sheath to assist, to provide that insulation, to allow that action potential to possibly move more efficiently. And then I need the neurotransmitter production to up its game as well, because if I haven't been needed, I'm not going to produce a lot. Now that I'm needed, I need to produce more so that I'm ready to go. And the body's really fantastic about reversing these types of things. We do it all the time. We think about it all the time when it comes to muscle fiber hypertrophy. With the neural side, we just want to think about, I want that to happen on the neural side too, right? And wow, 600 to 800 repetitions in 15 minutes is a really powerful workout for that nervous system. So that's the first type of physiological effect of PENS. The other one is that it actually sort of jump starts that muscle. It does that because we get this big outpouring of calcium in the neuromuscular junction. And this readily available calcium pool allows the actin and myosin in my muscle fibers to actually do a little bit of a stronger contraction. So what we can see after putting PENS on a particular muscle group is that that muscle group is going to have a little bit better ability to contract. Now, that's transient, but as a clinician, that's what I'm going to use to take advantage of in my session so that patient performs whatever I'm asking them to do a little bit better. That was my personal epiphany with PENS. I had a stroke patient that performed their gait pattern significantly better post-PENS treatment, and I started to ask myself, well, how did that just happen? You know, I hadn't had the education yet, and I didn't understand the physiology, but what I had seen that particular day was this excitation and this increased muscle contractility of their dorsiflexors, which improved their gait pattern. The other aspect, which I mentioned earlier in a previous slide, is that I will also get those type 2 muscle fibers. So now I have just more of the muscle active, and I have some of those fast twitch fibers active, which we use when we think about stuff like balance control or our ankle strategy, for example. We need those fast twitch fibers to be used to being called into action. Fourth physiological effect of PENS is going to be increasing local circulation. So this is happening because I have this high volume of action potentials being sent along the pathway, and I have a neurotransmitter that's released, which is acetylcholine. And we all know that acetylcholine, one of its main jobs is for vasodilation. So probably don't need to remind everybody, but vasodilation is usually always a good thing because we're going to be bringing in circulation and we're going to be getting rid of waste products. So that helps with a lot of different areas, but specifically just sort of to get things flowing and get a little bit of extra circulation into the muscles that we're trying to focus on. And then the fourth physiological effects of PENS is the fact that I'm going to have this influence that I mentioned before on the voluntary movement patterns, or our central pattern generators, which are our CPGs. So let's talk a little bit more about CPGs. CPGs are a collection of neurons. We have sensory and motor nerves. And sometimes there's some interneurons that help connect the loop. And these systems work together to run our basic movement patterns. So these are things that happen automatically. You know, we may initiate it with a cognitive thought, but then the two muscles, the agonist and the antagonist, do the work on their own. I really don't have a cognitive ability necessarily to change that. So this is sort of an automatic that occurs. We all have them, all mammals have them, and turns out they're species specific, which means the human pattern is going to be different than another type of animal's pattern, which is going to influence, again, our movement patterns. When we found this out and we figured this out by doing these EMG studies I mentioned before, came to the conclusion that, wow, well, if we can send the signals in the same way that they are supposed to be going via this patterned eSTIM program, then that's going to help me influence and almost return back or remind them back to a more normal firing pattern. So the CPGs are what we're targeting by this high volume very precisely timed pattern between a pair of muscles that normally work together. Therefore, pens can actually act in a facilitatory manner when that's required, or an inhibitory manner when that's required. And the cool thing is, it doesn't really matter. I don't need to make that decision. I'm just trying to return it back towards more normal. So I want you to think of this as a neural metronome. That's how I think about it, right? I didn't play piano. I've had friends that played piano, so I know what a metronome's all about. It's running in the background at a specific pattern or pace, a metronome. So picture pens running at the perfect pattern that we know normal movement occurs. If my nervous system has developed poor pattern or lazy pattern or delayed patterns, then it's gonna say, hey, you know what? You need to be here. You're not firing when you're supposed to be firing. Remember this, remember how this looks, remember this pattern. Let's get back towards that. And again, what's one of the keys to relearning a pattern, a movement? Repetition. As much repetition as I can do, the repetition better be appropriate or I'll learn the wrong pattern. And what is PENS doing but high volume of perfect patterning? So we're sort of tricking the nervous system into thinking that you just did things perfectly a lot of times in a row, which is going to carry over towards moving that needle or that bringing us back towards that metronome pattern that we want to accomplish. So on the inhibition stance, it's the same thing. Too much is happening. I'm contracting way too much. This is bad. This is impacting this person's ability to move independently. When I'm on, you're off. When you're off, I'm on. Let's not contract at the same time. So let's get back and remind the body of the more normal patterning. So I like that neural metronome. It kind of clicks in my head, makes sense to me. And then I just wanted to do a little research to talk about this. So what I was able to do is I just recently found, I was looking up abnormal firing patterns, triphasic, and I came across a study that was published back in 2015 on abnormal sensory gating in basal ganglia disorders. And what I wanted to draw your attention to is this pattern. Look, normal patterning, that beautiful triphasic pattern we just talked about. But look what they found when they looked at the patterning in a patient with Parkinson's disease. Well, you can clearly see it looks nothing like that triphasic pattern, and it's on and off and on and off and on and off and on and off, and you can see that there's really not probably very efficient movement going on between the agonist and the antagonist for that particular patient. Same thing down here with an example for dystonia. Look at all of the co-contraction that's happening. Imagine trying to move your arm with your shoulder flexor when your shoulder extensor is kicking on and sort of basically saying, no, not going to happen. You probably get a lot less fluid movement occurring. So I pulled this out because I'm a visual learner and I like vision. So this sort of was a great example of when the pattern is not right. We all know what Parkinson's disease looks like in the clinic, but we haven't gotten a chance to necessarily see what their pattern of firing is because we haven't done the EMG testing ourselves. So I thought this would be a great way to just sort of remind everybody that that's what we're trying to influence, because the closer I can get back towards normal, the better. Take a look at this study. It's actually an interesting study because what they ended up doing was stopping the sensory input and seeing what happened with movement. And interestingly enough, when they blocked the sensory input, the pattern returned, which sort of just talks a little bit about the fact that this is not something that, you know, we necessarily, we want to influence that positive sensory input as much as we want, as much as we can, because bad sensory input is leading towards a bad pattern. Okay, so kind of to summarize that whole piece, we want to re-educate the motor memory of these CPGs. I didn't mention it before, but these are all subcortical, right? They're spinal or supraspinal, but they're not in the cortex loop. We want a more normal output, and that means that I'm going to improve movement memory, or I'm going to improve the firing pattern. You know, maybe this person has premature or prolonged muscle activation. Maybe they have spasticity and everything is staying on too long. Maybe there's a delay or a lag. Maybe we're having poor activation. I didn't talk about this before, but one of our goals with neural strengthening is to remind the motor units to work together in synchrony. Really don't randomly fire. Let's all fire together. Let's practice that neural input so all those motor units are firing together. A good example of what happens when our motor units are not working together, or an analogy, is that, if you're having a team, or you're having a contest of, the rope pull contest, you have one team on the right, one team on the left. Well, everybody has to pull and work together at the same time in order to get the most effective, contraction. Same thing with our motor fibers. I have to work together to get the stronger contraction, and practice will help with that. So our ultimate goal, obviously, is voluntary movement, and that's going to help us with strength, coordination, and function. I'm going to be starting a little summary video that, again, as a visual learner, I think is super helpful to just sort of tie that piece together. It talks a little bit about repetition and how we know to recover from a neurologically involved injury. As much repetition, as much appropriate and good sensory input as I can give to that patient. That's why we do weight bearing, right? We do weight bearing so we get sensory input, and our goal is to have this automatic motor response happen. And the more times that appropriate response happens, the better. So this sort of summarizes everything about PENS. I want to just show you a little bit more about how this neuro re-ed can be helpful. I'm going to click the start, and at the end of this, when I stop it, we're going to talk a little bit about some patient ideas and different protocols.
Electromyography science demonstrates that the body uses specific nerve and muscle firing patterns to produce normal human movement, such as walking, reaching, jumping, and throwing. When bringing the hand toward the mouth, for example, the central nervous system fires the agonist elbow flexors, primarily the biceps brachii muscle. An antagonist muscle, the triceps brachii, is subsequently activated approximately 80% into this range of movement to slow the arm, creating a slight overlap of agonist and antagonist muscle activity. A final agonist muscle contraction fine-tunes the movement and stops the arm at the desired position. These contractions also overlap slightly. With disease or injuries such as a stroke, normal nerve and muscle firing patterns are disrupted, which can severely impair function. Research indicates that repetitive exercise mimicking the body's normal movement pattern is essential for recovery of function. However, achieving acceptable exercise intensity and duration is often a challenge, particularly with neuromuscular dysfunction. ACP's PENS technology replicates the body's normal nerve and muscle firing patterns to help facilitate normalized function. During a 15-minute treatment, PENS waveforms are applied 600 to 800 times repeatedly, re-educating nerves and muscles. This enables therapists to enhance outcomes for a broader range of patients and more medically complex conditions, such as post-stroke and neuromuscular disease. Additionally, this passive form of repetitive exercise can be used to activate and prepare muscles for therapeutic exercise and activities. PENS is gentle and effective, accommodating a wide spectrum of patients from elite athletes to aging adults. PENS utilizes neural drive to facilitate muscle strengthening while re-educating nerves and muscles. Other NMES waveforms seek to improve muscle strengthening through forceful, often painful contractions using firing patterns that have little in common with normal body function.
Okay, so it sort of summarizes everything we were talking about. I think that one of the cool things is, because I am just doing a tiny little muscle twitch, because really what I'm worried about is the nervous system side to that muscle performance. And the motor twitch, is really my visual confirmation that I have sent the action potential through both the sensory and motor sides of that central pattern generating loop. So I have this twitch contraction, and I can still then be working on anything else I need to be at the same time. So if I needed to have that person working on standing and weight shifting, or I wanted to have that patient potentially work on reaching tasks, I can still have that going while the PENS is running. And every then rest break that patient takes because they fatigue, they will still be getting this active PENS patterning during every passive rest break that they take. So now I have just added a second layer to my neuro-re-ed intervention that will be very valuable for all of the reasons we just talked about for the past 20 minutes. So I thought I would show you some examples of ideas. One of the things we run into clinically when we talk to clinicians is oftentimes there's so many muscles that are affected. Where do you start? So it really is depending on the individual patient and the goals. And I also like to toss in there, let's focus on the maybe muscle group, because we do need to do this PENS regularly. 3 times a week would be ideal for a couple of weeks to really get that maximum benefit. I can only pick 1 or 2 muscles to focus on if I'm working with a patient, let's say, that's had a stroke. What is impacting that patient the most will be critical. The other question I like to talk about is, well, what's the harder one for you to get other things active on? And I know, for example, having a patient be able to stabilize their shoulder is a challenge to get in the clinic. So I might be able to work on shoulder flexion a little easier, but scapular stabilization is much more difficult. So I'm going to choose possibly to do the setup that's involved in the scapular stabilization during my treatment to assist with that proximal stability of the shoulder and get a more effective use of the limb because I'm stabilizing at the shoulder. So this is an example up here in the right corner of the scapular stabilization setup on one side. This is obviously the right side. And what you can see, I clearly need both channels because I'm having channel A set up so that it's with the negative closer to the spinal column, which is proximal, if you want to think about that, to the other muscle belly. And then I have the serratus anterior and some of the lower trap muscles, rhomboids, working on this channel B. And this is going to be the agonist antagonist. Again, channel A being the agonist, channel B being the antagonist. And my unit will be running in a ABA pattern. Quadriceps, knee control, sit to stand, walking, any of that. Knee flexion extension is a fabulous tool. We might be employing that. That might be one of the key muscles that I've decided is important. Maybe this person has a shoulder subluxation. Let's pick a protocol that focuses on the 2 major muscles that are helping hold that humeral head up. So I'm working on the supraspinatus and the infraspinatus in this particular setup. And could I not have that person in a weight-bearing position, for example, while we're doing that, and possibly even working on stabilization exercises while I am performing the PENS treatment? Absolutely. I threw in the lumbar stabilization, kind of controlling that anterior posterior pelvic tilt, which comes into play a lot with standing, balance, gait, reaching in a seated position, seating and positioning. A lot of areas where we're really vulnerable is our core weakness. And this is targeting that combination of muscles that's going to work on coordinating that anterior posterior pelvic tilt and reaching left versus right. So all of these are examples of a triphasic patterning program because I have the agonist and antagonist on a single limb, for example, or working together. I did want to point out an example of where we would use a reciprocal pattern or a functional pattern targeting just the quadriceps, maybe in a pre-gait, maybe to work on symmetry. I want the right to work as hard as the left. I want the right to go, then the left to go. I want it to be rhythmic. I want it to be uniformly timed. So I'm reinforcing the right, left concept on somebody who might not be ambulatory yet, but I'm preparing that body to be a little bit more symmetry during their gait pattern. So those are some of the ideas that I wanted to kind of run through. We have a lot of opportunities for the neural reeducation, Parkinson's, ALS, MS, some of the neurodegenerative diseases. We would probably start off maybe with a shorter treatment time or just the sensory level because we are dealing with some neurodegenerative changes. That's something that when you reach out to your program coordinator. We can certainly make recommendations based on what you're seeing clinically, but this is just kind of a review of the physiology and some of the reasons why it's a great add to increase the intensity of your neuro workout with your patients in the clinic when they do have neuro reeducation needs. That's pretty much the end of my session. I wanted to see if take a pause here and see if anybody has any questions.
Okay, great. If anyone has any questions, please use the raise your hand feature and that'll move you to the top so that we can see that. So Deb, while we're waiting to see if anyone has any questions, thank you so much for taking us just a bit deeper into the science of electrotherapy for neuro re-ed. I myself am a visual learner, so I always love that video. And the analogy of a neural metronome is perfect for me in my head. So I thank you so much.